Sorry.
Okay, not at all. Thanks. So thank you, everyone, for joining. Sorry about that. I've been speaking into an intercom that apparently hasn't been working, so I apologize. But welcome to this next Born Ontario briefing. This session, as you would have seen in the invitation, is all around partnerships. And Marilyn Booth from the Provincial Council for Maternal Child Health and Jonathan Scollard, along with Mel Castellino from eHealth Ontario, are joining us today to talk about some of the partnerships with Born Ontario. So I think we're up to about 180 people online. That's incredible. We're so excited. So we'll dive in as it's 12:03. So before we get started in talking about some of our work and partnerships, I do have some great news to follow up on our previous call. You'll remember the last session was all around privacy at Born Ontario, and I'm ecstatic to announce that as of August 8th, we did get Privacy Commissioner approval for our policies and procedures and the way Born operates as a pre-HIPAA registry to be allowed to now collect personal health information without consent for the purposes of facilitating or improving the provision of health care. So you'll remember last time we spoke of registries as compared to entities and the like, and we had submitted to the IPC, and actually on August 8th, that final approval letter was received. And so Born is now fully operational as a prescribed registry, and incredibly excited about that. Okay, so it's all about partnerships today. You'll remember from the introductory presentation, I think up to almost 3 or 4 months ago now, we do refer to many of our key partners provincially and the various projects we're doing with them. And so we thought this would be a great opportunity to highlight a couple of those. Obviously, there are many, many, many more, and we hope to do maybe one of these annually every year, touch on 2 or 3 key partners with whom we work to really make the change it is we're trying to make provincially. And so as I mentioned, the Provincial Council for Maternal Child Health and eHealth Ontario are 2 great and quite different examples of how Born is partnering with other organizations to make a difference. Obviously, the Ministry of Health and Long-Term Care is a key partner. Ministry of Children and Youth Services, as we move more into childhood and the vision of Born, will become more and more of a partner through that. Public health we know to be a key component of what we do and an avid user of our data. ISIS is an entity we can partner with and share information with. Health Quality Ontario and their mandate around the Excellent Care for All Act is a great partner, as well as Service Ontario. But today, specifically, Provincial Council and eHealth. So to introduce it, I'm going to take you back to the stories we told in our very, very first presentation, the concept of facilitation of care and examples of what Born is trying to do to deliver that facilitation of care is best told through a number of stories. So those of you who were on the very first Born Ontario briefing will recognize these. So one example is that of best practice. So if baby Alice is born by an elective C-section at 37 weeks and 4 days to, say, a low-risk mother having a repeat C-section, she might end up in the NICU with some difficulty breathing or maybe not feeding well and struggling that way. Really, a C-section at 37 weeks and 4 is not ideal and is not best practice. And so the story we tell or the question we ask is, whose responsibility is it to monitor best practice? So Born, with the information that is stored in the registry and the information we have, we're in a great position to monitor best practice, but we're not in a position to define best practice. And that's where the Provincial Council for Maternal Child Health comes in. Marilyn Booth is the Executive Director of PCMCH. She and I have worked closely together for almost 2 years now, and I know her relationship with Born goes way back to the OPSS days, the Ontario Perinatal Surveillance System days as well. And so she's kind enough to join us today and talk about PCMCH, and then we'll talk a little bit about some of the examples of how Born and PCMCH are working together to make some of these changes and ensure best practice. So Marilyn, thank you so much for joining us today, and I'll pass it over to you.
It's a pleasure, Mari. Thank you. So the Provincial Council for Maternal and Child Health was created by the Ministry of Health in 2008. We have two distinct roles, and created by and is funded by the Ministry of Health. We have two distinct roles. First of all, we generate information that supports the evolving needs of the maternal child health care system in Ontario. So we dialogue with individuals who work in the maternal child health care system to understand what the key issues are from across the system. We negotiate a work plan with the ministry every year that addresses priorities both for the ministry and for the system. And much of our work is done by convening expert panels around a specific topic. Some of those topics have been acute care transportation for pregnant women, infants, and children. We've recently had a expert panel complete their work deliberating about neonatal abstinence syndrome. We've had a group on breastfeeding, a number of groups who've come together and looked at the literature, looked at data, and provided best advice and recommendations to the ministry and to the council about system change. And secondly, we're a resource to the maternal child health care system to support system improvement and influence how services are delivered. And while in our early days we focused mostly on generating recommendations and providing them to the ministry, and the ministry assumed responsibility for actioning those recommendations, we're evolving and beginning to take on a more active role in implementation. And one of the things that you'll notice if you visit our website is that we're starting to put recommendations from our expert panels that are the recommendations that are focused on clinical care onto the website. So we now have recommendations regarding breastfeeding, retinopathy of prematurity, and neonatal abstinence syndrome that are currently on the website, and will continue to build that resource for the province.
Perfect. Thanks, Marilyn. So some of the...
Mari, did you want me to talk about PCMCH and Born, or...?
Sure. Well, we'll go through the three examples, maybe.
Okay.
Three examples we have today is how the Born data actually supports the deliberations and the work of PCMCH expert panels, and also some examples of where our data has actually been used to roll out some of the new things that Marilyn was speaking of moving into that implementation realm. Birth registration and the information around birth registration in Ontario is something Born's been actively working on and looking to PCMCH for support as well. And then finally, how PCMCH recommendations and the Born data set work together to try to make sure we're able to collect all of the information required to measure and evaluate some of the recommendations being made. So, Marilyn, maybe you want to speak to the first example?
Okay. So certainly we have gone to Born frequently for information to inform the deliberations of the expert panels. And an example would be when we were looking at retinopathy of prematurity and services for retinopathy of prematurity, we needed to understand where babies at risk were born. So we went to Born for that information to try and understand where the targeted at-risk infants were being born, so we could look at the services that were available across those LHINs in comparison to the volume of infants. When we were looking at a whole number of recommendations, we needed to have some concrete data, and Born has been just invaluable. in providing that kind of concrete information that really has informed the deliberations of our expert panels. And then when we're looking at rolling out the new levels of care, as an example, that was a set of recommendations that came from our Access to Care group. There were a number of issues that came up as we looked at the designations for hospitals. One of the questions that came up was how many births really are occurring at hospitals that are non-designated providers of birthing services. So the natural place we would go for that information is to Bourne, so we can answer that question for the system.
Great. Thank you. So a second example, which is almost the reverse. So the first example that Marilyn used is when PCMCH is doing their work, then information can inform that work. And in fact, this is an example that's the reverse, where Bourne is delivering on its promise, so to speak, and needs the support of PCMCH to be able to do that. So we are working with Service Ontario on some challenges associated with birth registration in Ontario. So I'm not sure how many of you have seen the reporting of birth rates and things like that from Statistics Canada. There are certain instances when they can't be reported for the province of Ontario due to some data quality issues. And Bourne was asked to look at what the drivers of that were. And it is specifically, it looks to be, there's still more work to be done, but our initial understanding is it looks to be challenges associated with linking neonatal deaths with neonatal births, that the babies being registered at birth who may have died during childbirth or just shortly thereafter, the birth isn't actually always registered, and so there end up being data quality issues. So Bourne has been learning about this through the data and understanding the birth registration process, and has recognized there are likely a couple of solutions. One solution would require interministerial support and maybe even legislative change, so that will take a while to implement. But in fact, there are changes in practice that could be made to support data quality. So essentially, if hospitals were in a position to support families in completing all of the necessary paperwork associated with the registration of the birth and the death, that in fact, on the ground, so to speak, we could make the changes required to improve the information to allow us to report those rates more accurately in the province of Ontario. And so while, again, Bourne has the information, we need the support of the Provincial Council to roll out such a change and to work with the hospitals to make the necessary changes provincially to support this data capture and collection. And so Bourne has actually made an official request to the Council to support us in this work going forward. So it really is a bi-directional partnership where the Council works with Bourne and Bourne works with the Council to complete that equation of policy plus information to drive change. Marilyn, did you want to talk a little bit about how we keep our data and recommendations aligned?
Absolutely. So the expert panels have a broad number of recommendations, and most of the panels have also included indicators that will help to evaluate the recommendations. And once you have that whole set of indicators, it becomes essential then to start to look at is there data available to be able to implement those indicators. And it could be anything from, with our breastfeeding group, have we really increased breastfeeding initiation rates in hospital across the province? It could be with our mother-baby dyad group, looking at trying to promote kangaroo care and hopefully decrease admissions to special care nurseries. Have we really managed to accomplish that? So one of the things that we've done is pulled all of the recommendations and the proposed indicators out of all of our reports and sat down with Bourne to see what information is currently available and what information might be potentially available down the road. There are some things that, will not be collected by Born, but might be collected by another part of the system. For example, Critical or the transport system. But our first stop in looking at the indicators and how we might collect the proposed data was to Born.
Thanks so much, Marilyn. So those are really three examples of how Born and the Provincial Council for Maternal and Child Health are working together to try to make change in the community on a provincial basis. So with that, I'm going to lead into a second example, and quite a different example, which is why I love my job so much. The breadth of what Born gets to do is remarkable, and this next story is a very different story, but equally successful. So again, going back to the stories from the very original presentation, you'll remember one about Sarah, who, although living in Toronto, goes away with friends late in her pregnancy, has so much fun that she unexpectedly delivers, say, in London, Ontario, and because of the fact that she's not where she expected to be at delivery and earlier in the delivery than expected, her antenatal 1 and antenatal 2 information isn't available to the clinicians. And so obviously there's quality of care issues associated with that, but there's also costs of rerunning tests and the like that maybe had already been done but would have to be redone because the results are not available. This is one of the stories we've spoken to for quite a while, and there's a few reasons why this one resonates. Obviously, a great opportunity to facilitate care, to make sure that information is available to provide the best possible care across the province. A little bit more selfishly, from Born's perspective, is the antenatal 1 and antenatal 2 data is a key component, a core piece of antenatal care, and incredibly important as you're building an authoritative data set around maternal child health information. And so it's always been on our radar as something we wanted to do in the short term. So we were extremely excited when Beth Goodhue, our project director, introduced us to Mel Casalino, who is the director of the Physician eHealth program at eHealth Ontario, and he subsequently introduced us to Jonathan Scollard, who's my counterpart at eHealth. And we met, I think, a short 4 or 5 months ago, maybe, was the first time, to talk about the opportunities of nesting the antenatal 1 and antenatal 2 data collection in the provincial eHealth standards. From the very first day we met, it was recognized as a huge win-win, where Mel and Jonathan are looking to integrate essentially care pathways into the provincial EMRs, and Born is looking to make that information available provincially. It really was a situation where we both could get what we needed out of the partnership. And so I'm going to pass it over to Jonathan and Mel to speak a little bit about eHealth Ontario and then describe the pilot project that we're undertaking together.
Thanks, Mari. As everyone on the phone may be aware, eHealth Ontario, amongst many things that it does, provides funding for community-based physicians to adopt electronic medical records in their practices. And for us, community-based physicians means primary care physicians and certain specialists that work in community-based settings. So as part of that funding program, we're targeting about 9,000 physicians in the program by March 31st, 2012, and that equates to about 65% of primary care physicians adopting an EMR. Now, in addition to simply adoption of the EMR itself, part of the strategy is to increase the effectiveness of EMRs and related technology inside of physicians' offices by trying out new ideas, by running pilot projects to figure out whether new ideas will have legs for the rest of the province or not. And the project that Mari is describing is one of these projects. The fun part about these projects is that initiatives that do pan out, that do demonstrate significant value for physicians and for the system, can be embedded in a provincial EMR specification. That specification as part of our funding program requires that EMR software vendors make functionality that eHealth Ontario and its partner OntarioMD specify so that that functionality is available more or less by default to all physicians who adopt an EMR as part of our funding program. So the key opportunity there is if an idea does in fact pan out, our ability to scale that functionality provincially to literally thousands of physicians is a fairly straightforward path. So it's fair to say that eHealth Ontario is equally excited as Born is to be participating in this project. Mari, do you want to give the overview of what it is that we're proposing to do?
Sure, I'm happy to. So a little bit of a picture to try to describe what it is we're undertaking in this project. This is a pilot project, as Jonathan mentioned. We'll try it with a number of family health teams in a couple of hospitals to begin with, prove it out, and then hopefully have it integrated into the provincial standards in short order. But there's a number of steps involved. So the first step, obviously, is to identify the guidelines associated with prenatal care that will eventually populate the antenatal 1 and antenatal 2 forms. So going to the SOGC, going to NICE, RCOG, there will be a standalone project essentially to collect the appropriate clinical guidelines that providers will be provided within the provincial primary care EMRs to support the care of pregnant women and their families. And by integrating those guidelines into the products, we'll be collecting the information required to populate the antenatal 1 and antenatal 2 forms. So once that information has been collected in the community, it'll be passed to the Born registry, to the Born system, where it can be made available to labor and delivery units provincially. You'll remember that Born already has a relationship with all 109 labor and delivery units in the province to collect their labor and birth information. So we get to leverage and reuse that relationship to actually make the antenatal 1 and antenatal 2 forms available to those very same units, either in emergent situations, so the story of Sarah where her form's not available in the hospital, or even more broadly, that it becomes essentially a repository of these forms for women and hospitals across the province. So this is the architecture. This is the solution we are in the process of building. We're just kicking off the project now, but plan on working actively through the fall to identify our partners. Good afternoon. Can you guys hear me? Can someone just mention in the chat box whether you got me back?
Now I have you back.
Wonderful. Thank you. I'm not quite sure what happened. I suddenly got a busy signal. Sorry, Marilyn, how far did everybody hear the fact that the clinical pathways will be integrated with the EMR, the information will make it to the Born registry, and thereby be made available to the labor and delivery units?
Yes.
Did that make it through?
Yes.
Wonderful. Okay, I'm sorry about that, technical difficulties. But essentially that is the architecture we are working towards. The project has kicked off. The guidelines will be selected through the fall. The partner family health teams and hospitals will be selected through the fall, and we hope to kick off the pilot project, the actual implementation, late this year, and to track it through next year to understand the success and therefore use that to hopefully get this into the provincial standards sometime next year. Jonathan, is there anything you want to add to what I described?
No, I think that's a perfect summary, Mari.
Thank you. So two very different examples of how Born is partnering, but I think they're really good examples of how different organizations in the province have different responsibilities, but by coming together, we're actually serving each of our purposes better and driving to some real exciting change in the province. On the next slide, you'll remember our story as how we choose to grow with our system going live in the next couple of months and babies being born at exactly the same time. We want to grow our system at exactly the same pace that those children grow, and it's only through these types of partnerships provincially that we're going to be able to do that. Marilyn mentioned Critical. I mentioned ISIS. There's all sorts of organization that has key information and key what we call encounters associated with the information used in care that we want to partner with to be able to build that continuum and to collect this authoritative source for maternal child health in the province. And so I just want to thank Jonathan and Mel and Marilyn so much for joining today to describe a couple of the opportunities. And if any of you on the phone know of other ones that you think would be relevant and important to Born or to the partner themselves, please don't hesitate to contact me and let me know, because we are always looking to see how else we can accelerate the change. So with that, I'm going to ask you, I know in the past we've done phone questions as well as chat, but with the distributed team, I think today it might be best actually just to use the chat window on the left of your screen to ask some questions. So I've noticed one here. The first question we've got is, when speaking about EMRs, we speak about physicians, and what about an EMR for midwives? Well, first I'll ask Jonathan to speak to whether or not the physician eHealth program is specifically physicians or if it goes more broadly, and then I can speak a little bit to Born's role with primary care, both in the form of physicians and midwives.
Thanks, Mari. I'll ask Mel to answer that one.
Mari, it's a good question and very timely. So we are broadening the EMR adoption program to include other clinicians besides physicians. So currently we include community-based physicians and specialists. We have extended it now to include community health centers, and also include nurse practitioner-led clinics. So the intention is not to be exclusive. We are looking at broadening the program, and certainly midwives has been a topic of discussion with the Ministry of Health. So we're working with the Ministry to determine whether or not they want us to fund midwives and what is their timing. So it's really dependent on the Ministry and their direction to us, but we're certainly supportive of including midwives in the funding program.
Thanks, Mel. And I'll just add a little bit around Born specifically. As you know, midwifery community is a key component of the Born system. In fact, it was the integration of midwifery information with the historical NIDA information that gets us to pretty close to 100% capture of births in the province. And so the system has been built to accept data. The architecture of the system has been built to accept data either electronically or manually. So as EMR adoption occurs, whether in physicians' offices or within the midwifery community, we're well situated to collect that information. That being said, we are specifically looking at family health teams for this pilot project. And so the pilot project we spoke of today will be specifically around physicians. So it's not to exclude midwifery in any way, shape, or form in the long-term rollout of this, only in the pilot project. Okay, let me see if I can catch up with these questions. Bear with me. Including public health units in the pilot sites as well. I'm not sure I understand the question. For the pilot sites, we're looking for practitioners providing prenatal care to pregnant women in a primary care environment. So public health units will have access to the data that is collected and can learn from that, but I'm not 100% clear how they would be a pilot site as part of the project. Let me go to the next slide, and you'll get contact information, so info@bornontario.ca. If I'm not answering your question sufficiently, please drop an email there, and I'll do my best to follow up with you. Okay, is there exact guidelines of what is being added? Sorry, bear with me here. Is there exact guidelines of what is expected from the hospital? Will there be a portal to continue to manually enter data into the system, or is Born looking for data elements to be built into the electronic charting and uploaded that way? So for this question from GBGH, I think this is looking specifically at the Born build, which will continue to function as it has done historically, where data elements can either be extracted from electronic charting and uploaded that way, or manual data entry. That depends on your organization. The Born build briefings are the best place to get these questions answered with Beth Goodhue. So if I'm not answering it as in the amount of detail you'd like, then our next Born build briefing is the place to ask. But this, I will clarify that the Antenatal 1 and Antenatal 2 pilot project we're doing with eHealth is truly that. It is a pilot project and doesn't impact the broader Born build and all the work that's been happening on that over the past 18 months. So everything you've learned about the Born build stands. The way data, labor and birth information is collected for the Born build, all of that stands. The Antenatal 1 and Antenatal 2 project is just an example of a partnership of how we're looking to build the continuum and to collect more information. Okay, I'm not sure there are any more questions. Oh, a comment from Carmen. It's exciting to hear that Born is considering adding new data sources for child health surveillance. Could you please speak more about this initiative, and when can we expect to make use of those data sources? That's a great comment and question. So yes, absolutely. Growth is something we are exploring and planning for. In fact, one of the first steps was a bit of an environmental scan to understand what sources are available. I can't remember the exact number, but I'm pretty sure we explored over 40 different partners and 40 different sources of information in the province that would help build out our continuum. And the decisions have yet to be made of where to invest next. We're just rolling out the build through the fall and in parallel beginning our planning for what's next. So input is always appreciated into that planning process. But one of the underlying drivers of that process was that vision, that growth and development slide we looked at a minute ago, which is if we have labor and birth information for this cohort being born through the fall of this year, then what future data points can be informed by that starting point? So the favorite example I have is the 18-month well baby visit. Now that that's billable in OHIP and becoming standard practice, you can imagine that 18-month well baby results are an incredible source of outcome information for labor and birth information. And so we're very keen to work with the Ministry of Children and Youth Services and see if there is an opportunity to add that as another data point. And so by the time this cohort being born now is 18 months, we really hope to be able to collect some of that information, hopefully supporting MCYS in some way, but also supporting Born in an authoritative, comprehensive child health information repository. There's a question on whether the growth includes neonatal transport. Transport I find fascinating when you consider the cost implications associated with transport and the complexity associated with transport. So transport is one that flies across our radar quite regularly and seems to have a significant opportunity associated with that information. And again, as outcomes information, even things like levels of care and the like can be informed by transport. So I do hope we have the opportunity to find a partnership there to be able to make a difference as well. It sounds maybe like within the next couple of months doing a call like this one, a Born Ontario briefing, specifically on what some of those future sources are and maybe making it more of a discussion might be worthwhile. So I'll add that to one of our future agendas. Next question, what information will public health departments have access to? Will we require permission to access information from Born? So Born is partnered quite closely with public health. I have a few people I'm working with, and I'm happy offline to provide their names, but I don't think I'll do it in this public forum, on a couple of fronts on how we can make sure Born data is available to public health in a way that is meaningful to public health while still meeting the IPC requirements around personal health information. So we're exploring different options like a dedicated public health analyst working with Born Ontario who, as a Born agent, if you remember from the last call, a Born agent would be able to see the personal health information and work with that personal health information appropriately as per IPC and provide the data out in a way that is meaningful to public health. Another thing we're exploring is a public health cube. So for those of you out there who are as data geekish as I am, doing data analysis through a cube, an analytical cube, is a great way to navigate information and mine information. And so we are looking to create a public health cube that includes the data in the Born system that is relevant to public health, aggregated in a way that it's aggregated enough for the purposes of privacy and yet detailed enough to serve the work of public health. So again, follow up with us directly. I'm happy to point you in the direction of who I'm working with on that. But we're quite keen to make sure that we respect the privacy of the information in the system while still meeting the requirements of the people using the data. Okay, that was the last question. We'll give it another couple of seconds, but I appreciate everyone dialing in, as always, and thanks again to the Provincial Council and to eHealth for giving up your lunch hour to talk about the work we're doing together, and to everyone else who was willing to give up their lunch hour to hear about what Born is up to. We're really excited about the progress and expect the next few months to be equally exciting. So please dial in again 6 weeks from now for the next session. No more questions? Okay. Well, thanks, everybody. Take care.
Thanks,
Bye-bye.
Mari.
Thanks, Marilyn. Thanks, Jonathan. Thanks, Mel.